Next, we are going to start off with nephritic syndrome. What is nephritic syndrome? It is when there is severe glomerular injury that leads to inflammation. And remember what happens in inflammation? First, edema. Then you get white blood cells. First it's the neutrophils, but then for our case here, white blood cells come. And they are going to produce different substances such as cytokines against it will be against our own body's glomerular structures. So there's going to be cell injury. And what happens then? Now we are going to draw that image again. There's going to be let's assume there's going to be damage to the basement membrane wherever the pathogenesis is. So there's going to be severe damage. And what happens then? In this situation, even red blood cells will enter. Let me use red for red blood cells. Even red blood cells will enter. There's no need to ask about proteins. All of them will also enter. We get proteins, we get everything basically leaking into the Bowman space. And why I talked about red blood cells is because they are going to enter and go through these tubules. Now these are not thick tubules, these are narrow tubules. So what happens then? These red blood cells will have to squeeze through like this. And instead of the biconvex shape, these are going to become dysmorphic. RBCs must squeeze through. That means it is either going to become dysmorphic, like the morphology of those cells are going to be gone. The normal one is gone, so we call it dysmorphic. Or it could be something like they will be aggregated on top of each other to form a structure called casts. It will form a structure called casts. So it is going to have the shape of the lumen. Remember this. Okay. So these are the hallmarks for nephritic syndrome. First, we have painless hematuria. Painless hematuria with dysmorphic red blood cells and red blood cell casts. I explained how that happens. Next, we have oliguria and azotemia. Next, we have hypertension and low-grade edema. What is most important here are these. Remember, in this situation, you get hypertension. And there's 3 types of nephritic syndrome. First one is called acute proliferative glomerulonephritis. Next, we have rapidly progressive glomerulonephritis, and finally chronic glomerulonephritis. So first I will talk about the acute picture, acute proliferative glomerulonephritis. We'll talk about this one. The first thing you need to know is it is diffuse and affect all glomerulus. Affect all glomeruli. How? By immune complexes. So we can get it after beta hemolytic streptococcus infection, hepatitis B virus, and hepatitis C virus, HBV, HCV. These are the common causes. We get proliferation of endothelium and mesangial cells. Proliferation of endothelial and mesangial cells. Also, we get infiltration of neutrophils and monocytes. So, let me just write it. So we have neutrophils and monocyte infiltration. And we get granular deposits of IgG plus complements. And this is important. There is very high risk of thrombus in capillaries, which can lead to necrosis of capillary wall. Thrombi in capillaries plus necrosis of capillary walls. So thrombi can come here. It can lead to it can block off the blood supply, and it can lead to necrosis of this whole area. We have we'll talk about the prognosis of this. These patients can either recover fully, or they can go on to become the next stage, that is rapidly proliferative glomerulonephritis or chronic renal glomerulonephritis. So rapidly proliferative glomerulonephritis, that's next. Rapidly proliferative glomerulonephritis. It is also called crescentic glomerulonephritis. Crescentic glomerulonephritis. And if you don't know what crescentic means, it means a shape like this, like a half moon shape. Why does that matter? Because if you look here in this image, you can see the crescent shape. You get crescentic shape in this disease. So this is called rapidly progressive glomerulonephritis. From the name itself, you can tell what happens there. There's rapid progressive loss of renal function. Rapid progressive loss of renal function plus severe oliguria plus death due to renal failure in weeks to months. Remember in GI pathology we talked about a similar situation of the liver that is called fulminant hepatitis. So what happens here? There is going to be proliferation of cells. That is why you get so many cells, fibers, white blood cells here in this region. What are the types of cells that proliferate? It is going to be the parietal cells and the monocytes. These are the main structures that, okay, let's take an image here. Several images actually. Okay, let's take 3. So in the first one, I'm just going to draw the eosinophilic staining. I'll just draw it as red, and what is in red can be considered normal unless I draw something on this image. So we'll do the same here, and in this situation we will get the crescents formed. Let me use a different color. We get a crescent form. What is going to be the main type of cells here? It is going to be the parietal cells plus monocytes. So to this, the next stage will be fibers will deposit, but I'm still drawing the first stage. So to this structure, we get fibers coming and depositing, and I'm going to use a different color for that. I'll use green. Which molecule, which type of fiber comes? Fibrin. Can someone tell me where, okay, sorry, this is not a live class. Where do fibrin produce? Fibrin is going to produce locally, but where does the fibrinogen produce? Is it from fibroblasts or is it somewhere else? It is actually from the liver. Fibroblasts produce mainly 2 types of fibers, that is elastin and collagen. Fibrinogen is a coagulative protein which is produced in the liver. Simple biochemistry, do not forget these. Next, we get scar formation. This will lead to scar formation. So this is all progressive, how it progresses. And what I drew was actually the histology of it. Remember, when scars form, there is going to be contraction of the scar. Scarring. That's why I drew it smaller than the other 2. So we are going to divide crescentric glomerulonephritis into 3 types. Type 1, type 2, and type 3. So which is the most common type? This and this. It is the least common type, type 1. What happens in type 1 crescentric glomerulonephritis? Sorry. Type 1 crescentric glomerulonephritis. Type 2 crescentric glomerulonephritis. So in type 1, we get linear deposits. The first one, as I remember, for this class. So here are the normal structures, and to this we get linear deposits. What does that mean? IgG plus C3. And these deposits, what happens is, these deposits these immune complexes can travel to pulmonary, that is lungs, capillary, basement membrane, causing damage, leading to a condition called pulmonary hemorrhage. And this is a condition seen in a disease called, I don't have space to write here, but it's called Goodpasture syndrome. Goodpasture syndrome. So in Goodpasture syndrome, this is very similar to how I did Zollinger-Ellison syndrome. You need to know this because this is possible to be given as a case. Pulmonary hemorrhage plus renal failure. Renal failure. So these patients will have a history of these two. Type 2, you get granular deposits. Granular deposits. That's all you need to know about that. And type 3, there is no anti-glomerular basement membrane or immune complexes. You don't see this in immunofluorescence or electron microscopy. So basically there is some other pathogenesis involved. Okay. So that is it for nephritic syndrome. We get damage which is more severe, which leads to painless hematuria with dysmorphic red blood cells and red blood cell casts. You get oliguria, that is low urine production, less than 400 milliliters per day, and blood urea nitrogen and creatinine increased in blood. Also you get hypertension. That is it for nephritic syndrome. Final parts are pyelonephritis and chronic glomerulonephritis, that is from this, but I decided to put it elsewhere in the end. So pyelonephritis, what is that? Pyelonephritis is infection of kidneys. This is usually due to an ascending infection. What does that mean? So these patients will almost always have lower urinary tract infections, probably in the urethra, in the bladder, ureters, which will spread to the kidneys. Okay. Most common organisms are E. coli and Staphylococcus. E. coli is actually a part of the normal flora of our large intestine. So what does that mean? E. coli can pass out into the anal region and can enter into the urethra. So this is more common in females relative to males, and it can come up. That's why you get E. coli infection very commonly in females. The other route is through blood. So let me show you the way it spreads. This is going to be the descending aorta. These are the renal arteries. So I'm going to show you the two ways of spread. The most common one is always going to be ascending infections. This is our kidneys. These are the calyxes. The pelvis, the ureters. You have the bladder here. The urethra here. Look at the way I drew this side. Look at the way I drew this side. This is important. One type of spread is going to be bacteremia. Bacteria in blood can enter into the kidneys. This is one way. How do bacteria come into blood? This is more rare. This could be due to septicemia, or you have done this, infective endocarditis. The other method is from outside they come up. So it could move up due to reflexes, higher rate in females, diabetes mellitus patients, and genetic defects. So let's say there's going to be a reflux issue. There's going to be sphincter defects. So in genetic defects in sphincters. That will prevent the closure, causing refluxes upwards. So patients with genetic defects have a higher risk. And if you go to do some cystoscopy, I talked about different types of scopies, bronchoscopy. I talked about the vaginal examination, that is colposcopy. This is cystoscopy. So in these examinations, scopy examinations, you use natural holes in our body and send a camera in. So we are going to talk about the gross changes. Now think carefully and answer. In a condition such as nephrotic syndrome or nephritic syndrome, do you think both kidneys are going to be involved, or is it going to be just one kidney? Let's take chronic glomerulonephritis. Do you think both kidneys are going to be involved, or is it just one? It is going to be both kidneys. But in this situation, in an infection, unless the bacteria go to both kidneys, we get one kidney involved, and we get suppurative necrosis. What does that mean? We get pyuria, that means pus in urine. So there's going to be yellow raised abscesses. This is due to suppurative necrosis. And that can be seen very clearly in these images. You can see these yellow abscesses. So this first affects the interstitial tissue, that is the mesenterium. Then into lobules, tubules. Or if it affects the papilla, it is called necrotizing papillitis. It is when it affects renal papilla. This is more common in diabetic patients. So this is acute pyelonephritis that we did. Next, chronic pyelonephritis. Oh yeah. Before that, I want to talk about the clinical picture. So the clinical scenario are, there's going to be sudden pain in the waist region. In the back region, they have sudden pain. Sudden pain at waist. Since this is an infection, there's going to be systemic symptoms, that is fever, chills and malaise. So systemic symptoms such as fever, chills and malaise. Next, we have urinary findings that includes pyuria and bacteriuria. See, I told you, you can add different words in front of urea and that means something in urine. And also, there's going to be lower urinary tract infections. So there's going to be bladder and urethral irritation. Remember, you might not know it yet, but the fact that you differentiate between irritation and obstruction is very important. In obstruction, there is going to be, the patient is going to have very difficulty in passing out urine. They will have to strain a lot. In irritation, as the name says, it is difficult for them to pass urine because it hurts them too. And what is important is pyelonephritis. I have seen so many children come into the hospital and it is not a big deal. It is usually benign and self-limited. Usually benign and self-limited. That means it's less than a week. Next, you have chronic pyelonephritis. What is chronic pyelonephritis? This is an important cause of chronic renal failure. Important cause of chronic renal failure. This could be due to an obstruction or due to reflux. There could be an obstruction which is going to be called chronic obstructive pyelonephritis. The other type, it's chronic reflux associated pyelonephritis. And both of these are congenital. These are usually congenital causes. And this is going to be the typical appearance. You get blunted calyx and scarring. You can see the papilla has gone. There's no papilla. Yeah. Finally, we will talk about chronic glomerulonephritis, the last part of the lecture. And don't worry, there's very little there. So in this situation, type of chronic glomerulonephritis, the kidneys in gross appearance will look contracted. So I'm going to draw a smaller kidney. And it is going to have granules, diffuse granular. See, I'm showing both kidneys affected. That is important because in pyelonephritis, it's usually one kidney. Most of the time, it's just one kidney. But doesn't mean that it can always be one kidney, because the infection can go to both from the bladder, especially. So we get contracted kidney, red brown surface and diffuse granular. I forgot to mention about this image, but basically you can see the neutrophils, the white blood cells, the inflammatory changes that have occurred. It's all purple color, blue color. So back to this. This is the gross appearance. Next we have the microscopic appearance. In this, what is important is, over time, there's going to be scarring of glomeruli. And we get, if this is a glomerulus, there's going to be collagen deposited all around it. If this is a glomerulus, there's going to be collagen all around it. This is from a special stain, but we get collagen deposits. Next, the clinical picture. How do these people present? They have hypertension, they have azotemia, they have edema, they have renal insufficiency, What do you mean by renal insufficiency? It means the kidneys are not doing its function properly. For example, kidneys function to remove drugs from the body. So whenever you drink medicine, let's say you drink medicine for hypotension, for hypertension, that is, the medicine is going to decrease the blood pressure in the body. You are supposed to drink it 2 times a day, and our kidneys will remove it by the time the next dose is coming. So in renal insufficiency and renal failure, let's say the drug is not being removed. So what happens then? When the next dose is given, the pressure is going to drop even more in these patients. That can be very dangerous. Another scenario is sleeping drugs. So you give one dose and you give the next dose, and our kidney has not removed the first dose. It can actually lead to respiratory failure because it will paralyze the diaphragm. It can lead to respiratory failure. Remember that renal insufficiency can lead to a lot of different problems. This microscopic hematuria. What does that mean? If it is gross hematuria, you will see red color urine. But in this situation, unless you look under a microscope, you won't see anything. So if these patients don't undergo treatment for around 10 years, it is going to lead to a poor prognosis. That is uremia leading to death. If these patients undergo dialysis or kidney transplant, they have a higher life expectancy. So these kidneys are actually called end stage kidneys. That's it for renal pathology. This is the whole lecture for renal pathology. I hope you understood this. Let me quickly go through this again. The most common cause of glomerulonephritis is going to be immune complex deposition. If the damage is not as much, we can get a situation called nephrotic syndrome. There is no inflammation. The damage is not big enough to call the inflammatory cells. So there is going to be proteinuria and generalized edema. Next, if the damage is really too much, this could be primary or secondary, there's going to be inflammation. When that happens, there's going to be hematuria, and in urine you get dysmorphic red blood cells and red blood cell casts. I talked about how it happens. You get oliguria, azotemia, and hypertension. Next, we have pyelonephritis, that is an infection of kidneys. This is usually due to an infection traveling upwards. So that's it for renal pathology. We have one more lecture, that is infective disease pathology. Hope you understood this.